Our next keynote is from the Right Honourable Steve Barclay MP, Secretary of State for Health and Social Care. Please welcome to the stage the host of this session, Matthew Taylor, Chief Executive of NHS Confederation.
Thank you, everyone. Well, thank you for joining us at this year's ConfedExpo. Of course, we go on for a couple of hours after this session, but it is an opportunity to thank you for coming. It's been a really powerful session in which people have been learning and sharing together at a really important context. The 75th birthday of the NHS next month, the context of having come through a tough winter, stretching targets for us in the period ahead, the enormous opportunities of innovation that we've been talking about so much. But it's also actually these 2 days been important days for the health service in terms of policy. We've seen the response by the government to the Hewitt Review and the Health and Care Select Committee report, and today a new NHS mandate. And we welcome both those documents in terms of the general direction towards seeking to devolve more power to have a more strategic and focused centre. So in that context, it's particularly welcome that we have with us the Secretary of State to deliver a keynote address. We're delighted that he's come to us today to share with us the government's vision for this vital period for the health and care system. Just a reminder that if you'd like to put your question to the Secretary of State, and we hope there'll be time for a couple of these at the end, please get involved via the Slido facility on the ConfedExpo app. If you can, please restrict your questions to health and care only, not broader politics. But before we get to questions, we're all looking forward to hearing from the Secretary of State. So please join me in welcoming the Right Honourable Steve Barclay.
Thank you, Matthew. Pleasure. Well, thank you, Matthew. It's great to be with you here today. Tuesday's incident in Nottingham has shocked us all. I'm sure everyone's thoughts have been with the families of those who have lost their lives so tragically and all who have been affected. And I wanted to take this opportunity to thank in particular those in the NHS who responded, from the ambulance crews and the paramedics to the staff at the Queen's Medical Centre. I also recognise that this week brings additional challenges to many within the room in the context of the industrial action that we face. And I acknowledge this creates additional pressure for you and your teams. Many people will be working particularly hard to ensure the impact on patients is mitigated as far as possible. And I know this work comes after an incredibly challenging period. While the World Health Organization has announced that the COVID pandemic is officially over, its after effects are still very much being felt, including the scale of delays it has caused for patients waiting for treatment and the pressures on staff. Thank you to everyone across the health and care system for the way you're rising to meet these challenges. My motivation as Secretary of State is clear: to enable people to access the right care faster. Because when, for example, I think of cancer treatment, I'm thinking of the constituent in her 20s with a young daughter who was told not to worry about her symptoms, only to later find that the cancer had spread. I challenge myself as to what more I can do in this job to get the right treatment to people like her as fast as possible. That challenge sits at the heart of our 3 recovery plans. And whether it's electives, UEC, or primary care, patients are rightly demanding improvements. They also want to see care that is better joined up. And with our integrated care systems now taking proper statutory form, we are moving in the right direction. Last August, I visited the Jean Bishop Integrated Care Centre in Hull, which is one of a number of fantastic examples of how health and social care can come together under one roof. NHS staff, care workers, volunteers, all working to care for local people, including keeping thousands of frail and elderly patients out of hospital and helping them live at home with the independence and dignity they deserve. And with ICSs now fully operational, we can make this type of approach more commonplace across the country. Despite the difficulties we face, there are signs of progress. On electives, we've virtually eliminated waits of over 2 years, and we've reduced 18-month waits by over 90%. But we know the overall number remains high. This has a material impact, like, for example, the self-employed worker who's waiting for their operation before they can return to work. And this is why we are taking further action to expand patient choice and making information on patient choice much more transparent. On urgent and emergency care, ambulance handover delays have improved, but again, we know it has been particularly difficult in the past few days. And in primary care, more appointments are being delivered by GPs and their wider clinical team, with on average an extra 20 per practice per day. But demand remains high. I recognise many in this room will have played a direct part in bringing these additional services to patients. And alongside these plans, I know other important work continues apace. Now, you will have heard yesterday from Amanda about the improvements in cancer treatment, including the doubling of cancer checks. And in the 21st century, with the technology at our disposal, we can go further. Thanks to your hard work, we're already moving in the right direction. And take lung cancer as one example. Through our screening programme, we are now seeing more diagnoses at stage 1 and stage 2 in the most deprived communities. And this is a positive step and a practical example of how we are addressing health inequalities. We've also made particular progress in areas like breast cancer. And research this week shows that most women diagnosed in England will beat the disease. Now we must build on this by getting people to have their life-saving tests, checks and scans more quickly, bringing those checks closer to people. And that is exactly what the community and diagnostic centres are an example of. There are now 108 in operation. They've delivered more than 4 million tests, checks and scans, and they will help us build on the hard-won gains in the years to come. Now, I wanted to briefly touch on tech, and I know there's nothing original about a Secretary of State fixated with tech. But for me, this isn't about tech for tech's sake. It's the way we get the right care to people quicker and do so at scale. Take, for example, the way we're expanding the NHS app. Contrary to what you may have heard from one speaker yesterday, over 2.4 million repeat prescriptions were ordered in April alone, alongside 250,000 primary care appointments that were booked on the app, with numbers increasing rapidly. Tech is also the way we can tackle many of the frustrations that I hear from staff, and that I'm sure many of you in the room hear too. The reason I care about tech is simple. It improves outcomes and it helps you do your jobs. And let me say this, when budgets are tight, tech is often the first thing to go. That is not my approach. I am protecting the tech budget and those key investments that will help us in the long term, from ensuring every NHS trust uses electronic patient records and investing more in electronic bed management systems, to the significant investment we're making in our new data platform, to digitising the front line, from speeding up staff logins to staff passporting. Because I'm acutely aware that when it comes to tech, it is often how we make the job of local teams easier that is what really matters. Now, despite what some may have read, I believe strongly in devolving decision-making. Equally, I think that should sit alongside greater transparency. We need more devolved decision-making because it enables a place-based approach with decisions taken closer to patient need. But equally, there are areas of great innovation, but we have a challenge in how we scale those up so it is widely adopted. And this challenge is reflected in too wide a variation in performance between similar areas. For me, the opportunity is to evolve much more and to trust local decision makers, and in return, to expect more meaningful transparency. And let me give you a practical example of where I have applied this, even where it could have been uncomfortable. I listened to those suggesting we publish the number of patients waiting for 12 hours or more from arrival in emergency departments. And together with NHS England colleagues, we acted on that. And from April, we started publishing that information. This is particularly relevant in the context of mental health patients, who we know are at greater risk of longer waits in A&E, and that is why we're taking targeted action with the rollout of our mental health ambulances, the mental health cafes, and indeed the mental health crisis hubs. NHS leaders have been clear with me about what they want to see from the government: fewer targets and more trust in the system. As Matthew referenced, we published the new NHS mandate today, which reflects this. For over a decade, governments have used the mandate to make asks of the system. Sometimes these asks have been excessive, with long documents, with many pages, full of tests and targets. And I'm sure you won't be alone if you're sat there thinking, well, doesn't matter, I don't read it anyway. But what we've done this year is make it short and clear, setting out our priorities, cutting waiting lists, the 3 recovery plans, tech and workforce. It gives a clear direction and backs it up with the freedom and flexibility to deliver. We know that change happens when people are trusted, have a common purpose, and are free to innovate. It was something, Matthew, you highlighted yesterday as a lesson coming out of COVID, and it's something I very much agree with. Trusting ICSs with greater freedom from devolved decision-making alongside meaningful transparency was one of the reasons we commissioned this Hewitt review, and I'd like to thank everyone who contributed to it. Before I wrap up, I just want to reflect that as we sprint to address the present, it will be easy to lose sight of the foundations we can lay now to build hope for the future. Some, such as the long-term workforce plan, have been well debated by colleagues in this room. It offers significant opportunities, not just to boost overall numbers, but to better use the full skills mix of staff, to deliver training and career progression in different ways. And there are other opportunities, such as the rapid developments in AI, which are exciting and fast-moving and generating much interest. One example of the work we're doing with AI in the department is how we can use AI to improve patient safety in maternity services. And we're also working closely with the life science industry to enable both population-level treatments and more bespoke and targeted medicine. And this is reflected in our recent deals with Moderna and BioNTech, Lord O'Shaughnessy's review to speed up and expand the adoption of clinical research trials, which we launched last month, and indeed the Chancellor's citing of life sciences as one of his key growth sectors. The NHS has changed massively over the last 75 years, all while remaining true to its founding principles. And COVID showed that we can deliver change very rapidly when it matters, and that trust in local systems to make decisions allows them the freedom to better adopt innovation. And it is this culture of innovation which gives us the strong foundations for the next 75 years. So in closing, I want to reinforce my message today on the importance of trusting integrated care systems more. What that means for you is greater freedom, fewer targets from the centre, more meaningful transparency on performance. That is the approach I am taking as we work with you on our shared challenge of making it easier for patients to access the care they need. Thanks very much.
Thanks, Stephen. I think that's a message that will be very much welcomed. Let me spin through a few questions that have come to us from members. I'm going to start with a really cheeky one. On a 10-point scale, when 10 is absolute certainty and 0 is absolutely no hope, how likely is it we'll see a long-term workforce plan before the 75th birthday of the NHS?
Well, it's great, Matthew, to hear that excitement and interest in it. I'd say sort of an 8 or 9.
An 8 or 9. We'll take that. Thank you. Obviously, there are folk outside the centre today protesting as part of the junior doctors' action. Steve, you know that the system has taken on, through the planning round with NHSE, some really stretching targets for performance and finance. And these strikes make those stretching targets even more difficult. What hope can you give us in terms of a way forward in that dispute? Because sitting on the outside of it, although of course we NHS employees as part of the Confed, it does feel the core issue, the money issue, it does feel quite intractable. Do you have any sense of hope that you can share with us?
Well, yeah, and I recognise, Matthew, I mean, it's in my interest, obviously, because of the 5 priorities that the Prime Minister has set out. The one that sits with me, cutting waiting times, obviously relies on us moving forward in terms of working closely with our clinicians, working innovatively, and how we address that. I think there's been progress if I look at the discussions we had with Sarah Gorton and trade union colleagues on the NHS Staff Council. We had very intensive discussions. We reached an agreement in terms of a consolidated amount for this year and a lump sum, but also a wider package of measures within that Agenda for Change agreement that was agreed with the NHS Staff Council, which we're now working through with trade union colleagues. In terms of the junior doctors, we had 3 weeks of intensive discussions. We responded constructively to their request, which was to bring in a very experienced intermediary, a very respected figure known, I'm sure, to many in the room, Cathy McLean. But to date, we haven't seen any movement at all from the 35% demand that the junior doctors have made. And I think there needs to be, always with these things, movement on both sides. And we've set out as part of our discussions both a recognition of the offer that we made linked to a lump sum, but our desire to work on a wider package with junior doctors. But I think when I think of the other challenges that government has, and when we reach these decisions on a cross-government basis, how we tackle the challenge on inflation, how we cut the debt, how we grow the economy, those are 3 of the 5 challenges, and we've got to balance that with the needs of the NHS. And then within the needs of the NHS, you started quite rightly, Matthew, with highlighting the long-term workforce plan. We need to think not just of the importance of pay, but the importance of numbers. We also need to think of the importance of investing in the NHS estate. We just announced over £20 billion for the new hospitals programme, the biggest ever investment in the NHS estate. And then we also need to invest in tech, which was one of the themes I was trying to bring out in my remarks. So it's a common of things, but we want to work constructively and stand ready to have further discussions.
Thank you. And it's not appropriate for me to be lobbying you as you sit here on the stage, but I would just say, if you could look at the issue of people who work for the NHS but are not employed by the NHS, who've not been included in the backdated element of the agreement that was reached. There's an anomaly there, which particularly for the community sector is really challenging. Anyway, let me move on. The Prime Minister is committed to reducing waiting lists, one of 5 targets. I'm sure you get lots of phone calls from number 10, unless things have changed a lot from my time. What exactly does the Prime Minister mean when he talks about reducing waiting lists? Is it the overall number? Because in a sense, that's a function in some ways of whether we're diagnosing people of primary access. Is it the length of the waits? Is it just elective waiting lists? Or what about those waiting lists for children's psychiatric services, for example? So what is the Prime Minister committing to on behalf of the nation, just so we understand?
No. So I think, firstly, in terms of the 5 pledges he set out, it is very much what is articulated in the electives recovery plan. And that's clearly making progress, with the 2-year waits being virtually eliminated in the summer, the 18-month waits more than 90% cleared. And there's further targets in that around 65 and 52 weeks, and that's what we're doing. And again, when we look at some of the wider challenges that you just highlighted on the long-term workforce plan and pay, it's worth remembering we put an extra £8 billion of RDEL into the elective recovery plan and over £5 billion into the CDAR, the capital budget, for the diagnostic centres, for the surgical hubs, 43 new or expanded surgical hubs this year, 160 community diagnostic centres. So there's significant investment going in, recognising that in terms of the target it is to, as set out and agreed with NHSE colleagues, what our targets there, and that's what we're working to. And fantastic work by the likes of Sir Jim Mackey, Professor Tim Briggs and others in terms of that. Now, what sits alongside that is obviously, as you touch on, there are other targets in terms of weights as well. So the ambulance handovers in the UEC plan, how we collectively tackle the challenge of delayed discharge and our integration with social care. And within primary care, we put additional funding in with Pharmacy First and into GP technology and into additional roles. So if I look at the primary care weights, I think everyone in the room knows there's a challenge with that 8 a.m. Monday morning rush. So how do we firstly invest in the tech to make it easier for people to have the telephony in the cloud, the online booking? How do we make it easier for them to get the right care, which might not always be from a GP, it might be from some of the additional roles. We had a manifesto target for 26,000 additional roles. We've actually exceeded that, 29,000 now recruited. But then we've also addressed, and this is where I think active listening is really important in a role like mine. And so one of the things certainly raised quite strongly with me was there'd long been a discussion on pharmacy, and people felt we weren't fully using the skills mix within pharmacy. We had a lot of very well-trained people, but we weren't untapping the full potential that they had. So you saw significant additional funding into Pharmacy First. And then what we're doing is trying to combine that with the work of Joe Harrison and others on the NHS app, so that people, if they want an oral contraceptive, they may go and get it from the pharmacist rather than need a booking from their GP. So we start to think about what is it the pharmacist can prescribe, but do so, again, in a responsible way, so not losing sight of antimicrobial resistance. So thinking about what are the safe ways of enabling them to prescribe more, the 7 additional areas. So it's bringing the 3 recovery plans together with our investment in the NHS estate, with our investment in tech. But in terms of your starting point, the 5 pledges from the PM and the one that relates to health, it particularly speaks to the electives recovery.
Okay, which means it's really about long waits. That's the thing at the forefront of it. Yeah, got it. Well, whilst we're on the subject, talking about pharmacy, one of the questions which I think is an issue close to your heart is what can we do to accelerate the uptake of effective, innovative medicines? That must be a subject that is often brought to you. Do you have a view about what we can do in that space?
I think it's how we empower the patient more. And so how do we make that easier for them to sign up to clinical research trials? Is one aspect. How do we build our relationship with employers more? So if I think, many employers will pay more than the statutory sickness absence, so the statutory amount. If a member of staff is off for a long period of time, obviously that is a cost to the business, both the loss of the employee, but also the additional cost. So actually, how we work with employers more, how one of the big themes we're spending time in the department on is how do we take the innovation of COVID and apply it in a more peacetime setting, or without some of the challenges of that COVID period. So how do we take that into innovative medicines? And I think that's working with the deal we did with Moderna and BioNTech. It's looking at our life science program. But I think ultimately it's about empowering patients more, trusting patients and I think the more we can empower them, I think the more they will engage.
Let's take a couple of areas which weren't featured in your speech. So one is social care. So, we as a Confed have been saying for some time now that actually if you were given extra money to spend, we would say social care is the number 1 priority for the health service, as well as for social care, because of our dependence, our mutual interdependence. And not just because social care colleagues help us get people out of hospital, but also because social care plays an incredibly important preventative role. This issue of social care reform, social care funding, it feels like the toughest policy question of all, and one that hasn't fared very well in general elections in the past. What's your vision for how we can take forward the debate about social care?
I think there's 2 different issues, Matthew, and I did mention it in the speech in the context of the integration, because I do think how we integrate between health and social care is the sort of point, quite rightly, you have made and many in the room have made. And I think if I look at the autumn statement, for example, and there's advantages in having a Chancellor that was the longest serving health secretary. And one thing he made, well, probably the most important thing within the autumn statement was the extra funding up to 7.5 billion into social care. So it was Jeremy's priority in the autumn statement. So I think there has been a lot more focus on that. Certainly with the UEC plan, we've been looking very much at the handover points, both the handover points within the NHS, but the handover points with social care, looking at where the blockages are. Part of it is a money issue, but part of it is also how do we streamline. So when I was, for example, at Blackpool Victoria Hospital, one of the striking things there was because they get lots of tourists into Blackpool, they deal with lots of different local authorities, all with different forms, formats, and so forth. So I think there's a lot we can do with the discharge hubs, lounges, and how we look at that interplay between the NHS and care, and that includes the handover points, particularly at weekends. In terms of reform, I think there's a separate debate around, if I go back to the political side, and what happens in terms of people's assets and their homes, which is separate from the reform in terms of how do we have better career progression, a career ladder, what are the professional qualifications in care, how do we integrate staff roles more between health and social care. And the reason I was so keen to highlight the Jean Bishop Centre and my visit there was, what was striking for me was how much the staff enjoyed working. So the social care staff said how much they enjoyed working with the NHS in an integrated way, whether working together and vice versa. And so I think the more we can break the barriers down, yes, money is a factor, and the autumn statement spoke to that point, but I think there are also things we can do to streamline the relationships. And I think the Centre in Hull is a good illustration. And of course, following on from my point about devolving more decision making, when you take these at a more place-based level through the ICSs, I think you better empower commissioners to look at what works for the geography on the ground. And that will be different between a metropolitan area in some cases and a more rural area. How does it play the voluntary and community settings in? So let's do that through the ICSs, give them more freedom, devolve more decision making. Money is part of it, but it's also about working patterns.
I think there's a lot of enthusiasm within systems for joint workforce planning between social care and health in terms of that, developing new career pathways and opportunities. What about prevention? In your response to Patricia's report, recognise the case for more investment in prevention, didn't want to commit to the 1%. What's your view of how we move to a more preventative system, particularly when, with an election coming up, that kind of work that has a longer term consequence is harder to win support for?
I think it's the most exciting area, actually. Colleagues will have seen the announcement we made on obesity last week in terms of making sure the NHS is at the front of the queue for the most innovative treatments to address obesity, but also being innovative in how we deliver those. So instead of it being reliant on secondary weight management services, start to roll out those treatments through primary care, which is what we're piloting. I think the stats are so compelling, Matthew, on prevention. I know you've spoken very eloquently about this, but obesity being the second biggest cause of cancer after smoking, 9 of 10 type 2 diabetics being overweight or obese. So I think the case is compelling. In government, we're looking at our conversations, for example, with the OBR as to how we score things in terms of the impact on the labour market, because obviously that relates, as you know from your time in government, to some of the conversations on scale that I can have with government colleagues. But I think there's huge opportunities, again, coming out of COVID, to think about more home testing, think about the Internet of Things and how that combines with big data and clouds, storing data on the cloud. I think there's a huge opportunity on prevention to empower people. So philosophically within government, we take a much stricter view in terms of, firstly, what can we do to protect children, which is particularly relevant to the vaping debate, but in terms of adults, less about banning and more about empowering. And I think within the empowering, we start to look at where technology is going. I think there's huge opportunities to empower patients so that they can then make active decisions as to what to do. And that's why, for example, the conversation with employers is also quite relevant in the prevention space. So I think prevention is hugely exciting. Obviously, COVID cancer vaccines is one of the life science deals we've been looking at. So I think there's lots of different areas. I mean, 80%, just as to give you one example, 80% of the British public go through a major supermarket once a week. So one of the conversations we're having is how do we start to use our conversations on prevention to get information and empower patients, combine that with things like the NHS app. I can see Tim Ferriss has done brilliant work with NHS England colleagues about how do we get technology to better empower people, how do we build the partnerships with employers, how do we use home testing? Because for me, the real opportunity on prevention is early treatment has far better patient outcomes, but it's also far cheaper. So that then gives you more to reinvest in the system. So instead of waiting for someone to get the symptoms, hope that they go away so they leave it a bit, then finally feel they have to go and see someone, then have to wait and so forth, the more we can pick up and detect things early, perhaps even before someone's got the symptoms, then that has a massive impact. I always think show matters more than tell in politics. So a great example of that is the lung cancer screening, where we're now picking up stage 1, 2. That's why I highlighted that. But there's others. The 100,000 babies we're now screening through Genomics England. That's really relevant for rare treatments. Because again, there can always be a political debate around the overall quantum of funding. But whatever funding is then allocated, often it's the rare treatments that struggle to get the funding, as you well know. And if we can start to think about our relationship with Genomics England and how we pick that up, then that allows us to target. And the final thing as well with the prevention for me is, if I take antibiotics and AMR, which Dame Sally's been doing a lot of work on over successive years, if we can identify what the right antibiotic is first time, again, that is hugely beneficial to the patient, but it is also very beneficial for AMR and also for cost. So I think the prevention is massively exciting, and I think we've got to move away from some of the, dare I say it, tired debates around what do we ban, and actually look at how we're embracing technology, screening, genomics, testing in the home, working with the employers, picking things up early, because the sooner we pick things up, the better the patient outcomes. And a great final example of that, which I absolutely loved, is the HIV screening, where in emergency departments, people are asked if they'll opt in for HIV screening. And what the guys were telling me is, first it picks up some cases of HIV people don't know they have, allows you to treat them early, which is hugely effective from a patient outcomes point of view. It also stops them inadvertently, because they don't know they've got HIV, inadvertently passing that on to someone else. And obviously, it is hugely cost effective as an outcome. So how we look at the prevention, but shift it from some of the past political debates, if I can say, I think is a massive opportunity.
Well, I know you've got to get your train, Secretary of State. We're nearly running out of time. So just one last question, which is that I think for this audience, for the health service, the issue of health inequality is one of the 4 objectives for systems, and also our commitment to equality, diversity and inclusion in our staff. These are very important issues to us, and sometimes those concerns around inequality, around EDI, can be caricatured. I think it's really important to people to know that the Secretary of State takes those issues seriously.
Yeah, hugely. And perhaps if I, as it's your final question, finish with a collective challenge, which I think we all face, but I think it's a real opportunity for the NHS Confederation and others to play a part, which is our relationship with AI and the opportunity of AI. If I look at other sectors like financial services, there's a lot of concern that AI could lead to exclusion, people being priced out of products. But I think within health, there's an opportunity the other way, for actually AI to really highlight those health inequalities and use that data to actually address them. So I mentioned the work we're doing in the department around maternity. Through looking at AI, the more we can identify early which mums are at greater risk, the more we can address some of the health inequalities we see. So I think there's a real opportunity with the prevention work, with some of the screening, the targeted we're doing in the most deprived communities on lung cancer as one example. But I think there's a real opportunity on AI to think about AI in the context of health inequalities. And I think it's important we don't go down the road we did with GM food, where we lost quite a few years because there was a lot of concern on the science, Frankenstein food debate. I think there are risks with AI, but there's massive opportunities. And I think how we work our way through that collectively and how we use AI to address health inequalities, I think is one of the big opportunities. And I'd be very keen to work in partnership with colleagues in the room, because I don't want to lose several years as we have the wrong sort of debate on AI without actually seeing that it could be a real force for good if applied in the right way with the right safeguards.
Well, thank you so much for joining us today, for your speech, and also for answering the questions that have been put forward by members. Can I ask you to join me in thanking Steve Barclay?